All right, let's go to the next case. The next case with Dr. Watson is going to be a 70-year-old man who presented with left arm and left chest swelling and occasional hot flashes. He underwent imaging with a CT scan that demonstrated a 9 by 7 by 5 millimeter lesion of the head of the pancreas, and then underwent EUS demonstrating a 6 millimeter hypoechoic lesion. FNA was performed, which demonstrated low-grade neuroendocrine tumor, WHO grade 1. A chromogramin A and a CA19-9, they were both checked and within normal limits. The patient was presented at multidisciplinary tumor board, and the decision was to proceed with EUS-guided radiofrequency ablation. So we'll now switch over to Dr. Watson's room.
Okay, guys, so thanks for the case introduction here. So again, this is a incidentally discovered asymptomatic non-functioning pancreatic neuroendocrine tumor. Diagnosed by CT, and then follow-up EUS confirmed the diagnosis on FNA. So he was referred to us. We have a multidisciplinary conference here with our surgeons, radiologists, and so forth, and discussing options for this guy. He's a little bit of an elderly guy, but otherwise robust. And the question is, what can we do for these? And we encounter these quite a bit in our practice, right, with the EUS, and even in cases where we're referred a case for, say, a pancreatic cyst, and we find these small PNETs or neuroendocrine tumors, and the question is, what do we do with them? We know that low-grade, WHO grade 1 tumors are relatively benign and indolent, but of course, for patients and anxiety and so forth, we're sort of pressed to do something about it. So in this situation, this patient, we discussed it with him in terms of options, and he was interested in having a minimally invasive treatment. What was provided on the table is EUS-guided radiofrequency ablation, or the interventional radiologist also offered irreversible electroporation, but of course, with that approach, it's a bit more invasive, and so he elected to come see us. Now, I don't know if this is going to project so well, but it's such a small lesion here, but you can kind of see the lesion sort of in the center of the screen. I'm going to use the pointer to help guide us here, but this is the lesion essentially right here. Very subtle, not typical of what we'd see with a neuroendocrine tumor. We like to see them as very round, well-demarcated, homogeneous hypoechoic structures. This one a little bit more irregular, but again, we do have FNA confirmation of the diagnosis. And there's our size, so it's about 7 to 8 millimeters in maximal size here in sort of the head neck region. So when we talk about pancreatic RFA, so the device that we have today is available from Taewong, and it is a catheter-based device. If we can actually start to show the in-room view, we can kind of take a look at the device for the audience. But the idea here, there are various devices that have become available over time. This is currently available from Taiwan. Maybe we'll find a background. Maybe hold up the package there so we can get a better sense of the view here. We can bring the lights up too. So there are various devices that have come and gone over the last couple of years. This device now is currently available. So it's a solid catheter. I don't know if you can appreciate that. Perfect. So, great. So we'll show the catheter in a moment. 19 gauge in size. Okay. I'll bring it down a little bit. Yeah. Okay. That's the best we can do there. All right. So 19 gauge in size. Essentially a solid device. So, for example, when you think about the Habib catheter, it was a small sort of one French catheter you thread through an FNA needle. This is its own dedicated needle. If you look at the back handle, it looks basically identical to a standard FNA needle. Solid at the tip. So basically it's 19 gauge. We're going to access the lesion and ablate. It comes in various sizes, so 5, 7, and 10 millimeter needles based on the lesion that you're going to ablate. This particular device is interesting because it is internally cooled, which means that we do have a bag of saline up. We tend to cool the bag of saline itself. And then it actually runs through the catheter and internally cools the catheter to mitigate the risk of charring the tissue and any collateral damage. The other thing to note, and it'd probably be difficult for you all to see, but there is an insulated tip just behind the ablation zone. So in other words, the distal tip of the catheter has 5 millimeters of ablation zone, and then the gold colored area upstream is insulated so we don't have collateral damage to the pancreatic tissue. So again, 3 different catheter sizes. We use 3 different energy levels based on the catheter size for the ablation zone. For the smaller catheters, so the 5 millimeter catheter, we're looking at an ablation zone of around 6 to 7 millimeters of ablation, and then higher with the increasing size of the catheters. They do have a proprietary generator that delivers the energy. We try to treat with essentially a lower wattage for a short duration. In other words, we're trying to avoid charring the pancreatic tissue, and of course the big concern there is pancreatitis. The other thing to watch when we're ablating the tissue is to look at the resistance in the tissue. So in other words, as we're burning and applying the energy, we want to see that resistance rise, and that'll tell us that we're desiccating the tissue properly. So in terms of using this, so this has a clearance for soft tissue ablation, so pretty broad. But of course, the data so far has examined functioning and non-functioning neuroendocrine tumors as well as pancreatic cysts. Now, the biggest concern, obviously, as we apply energy to the pancreas is pancreatitis, pancreatic duct leak. The other issue is causing bleeding. And with the RF energy, it's going to be drawn to vascular structures as a heat sink, and we worry about causing a rupture of a vessel, which would obviously be catastrophic. So as we examine this area, so let's see if I can get my pointer here. Here's our lesion. If I throw the Doppler on here, here's our portal confluence here, okay? And the lesion is sitting just underneath there. As we rotate across, we can see there's actually a small branch. Again, hopefully it projects well on the screen over there, but there is a tiny branch, a venous branch off the portal confluence there that is running right deep to the lesion. That gives me a little bit of pause in terms of actually ablating this lesion. The other issue is too here is this structure here that doesn't pick up Doppler signals, actually the bile duct coming through the area. So in this instance, we have the bile duct abutting on the left side, and then we have this vascular structure running sort of deep to the lesion there, that we're kind of subtly picking up on Doppler. So generally when we ablate, we want to have at least 3 to 5 millimeters between the ablation zone and these critical structures, just to mitigate the risk of damage and of course leak from either one of these structures. In this instance, I've kind of debated back and forth whether we ought to do the ablation. I don't know if the panel has any comments, if you guys are going to vote one way or the other. From my point of view, it does give me pause that we are going to be ablating a lesion that abuts a branch off the portal vein, and we also actually have the bile duct fairly close. When I counseled him on it, it's exactly what he said. He said, I don't want this in me, I want it out. And despite discussion with both our surgeons and oncologists about the low-grade nature of this thing, he wanted it out. I actually agree, and I counseled him actually rather conservatively, saying that, look, surveillance is an option for this. There are other options on the table as well. And I'm not going to perform a procedure if it's going to cause you harm for this sort of essentially indolent sub-centimeter neuroendocrine tumor. Yeah, I had done that. I'll do that again. And I didn't have the best view. In fact, I spent some time searching for it down there in the hopes that maybe I could get a better look at it. But I haven't really gotten the best view. Let me just zoom out a little bit from the bulb. So that was basically all I was left with, was coming from up there. My bias is that I'm not going to do the ablation today. Again, the patient comes first during these courses. So I'm going to defer, and I think we're going to head over to Dr. Binmuller's room in a moment.